As we talked about yesterday in the lecture about the conduction system, one of the things that when there's an issue with the conduction system, they need to treat it in a certain way. So pacemakers are used. We talked a little bit about pacemakers yesterday. We talked a little bit about the two different types. There's a temporary, which I talked a little bit about, where you put it in for short-term use, and then either the condition has been resolved or they're able to go back in and put a permanent pacemaker in. If you look in the book on page 774 at box 3512, it gives you the indications for pacemakers. Pacemakers, with them, the power source, the thing to remember about them is the power source is going to be outside of the body with it. If you look at the figure on 35-25, it shows you what it is. The doctor is able to set the pacing, what he wants the heart rate and stuff at, and it is taped to the outside of the body once it has gone through the femoral artery and the leads have been implanted into the heart. With it, which means this is why it is a temporary thing. Sometimes there's just a problem with an arrhythmia and they can get the pacemaker to reset the electrical conduction of the heart. So that's why they may do it. But as in the case that I told you about, her heart was so badly damaged and stuff, she needed to have the permanent pacemaker, but until we could get the infection down to where we could go ahead and safely open her up and implant it subcutaneously, we had to do a temporary pacemaker on her. Now the permanent pacemaker is, the power source is probably about the size of maybe, I would probably guess a credit card. It's not really very big, and you take that and you plant it. It is usually implanted over on the left side of the chest, in the upper chest, and it's implanted subcutaneously with leads that run into the heart. It goes down to one of the leads will go into the right ventricle. It is then, once they get the lead wires where they need to go implanted into the heart, then the tech from the pacemaker company will, with the doctor, sit there and decide where they want the limits for it to kick in and start with that. So they usually have a parameter with some of the pacemakers, because they're meant to pace the heart. If the heart rate drops down below like 60, the pacemaker will kick in and start, take over for the heart, help the heart beat along. And they sometimes will have it to where it's set a little bit, higher. If it's like gets up to 100, then the pacemaker will, not do anything. So it's kind of one of those things that's meant to help the heart with it. Once they're done, with the pacemaker, they've got all the parameters set in, they'll close up the area and use some sutures and steri strips and close it up and put a band-aid on, and the patient can go home that day. If they've already been admitted to the hospital, we usually send them right upstairs with it. The thing is you will need to, when you educate them, they will need to have a sling and be careful with how they move their arm until that heals. Now the biggest thing that you need to watch for when you have somebody with a pacemaker is signs and symptoms of infection. Make sure there is no infections at the surgical site. And that's one of the things that when you discharge the person, even though the cath lab will do and the doctor will do their education, you will also need to reinforce the education of what to look for as far as signs and symptoms of of infection are at that site. Now, I also talked a little bit about an ICD. And an ICD is what we call, like I said, it's an implanted cardioverter defibrillator. It is one that is implanted that if there's a certain heart rhythm that they have programmed in for it to watch, such as like AFib, the heart will shock it. It is just like a little mini defibrillator that is in there that is meant to shock the heart. So when you have somebody come in and they say they have a pacemaker, you need to ask them, and they will know if they have an ICD. They may not know it by the ICD. When you are assessing them, what you need to do is ask them, do you have a pacemaker? Yes, do you have one that will shock you if you have an arrhythmia or a dysrhythmia? And a lot of times they'll say yes. So if that does, then you need to tell them. Ask them, when was the last time you were shocked? Then when you are putting the person on telemetry, you need to go in there, and there's a little box on most telemetries and ECGs that says pacer, and you need to check that because you're going to have these extra little spikes in there that you don't know what's going on, but you need to have pacer. You need to put mark pacer, so that way it will indicate on the EKG that there's a pacer in there with it on that. So just kind of a couple little tidbits on that. If you want to know a little bit more about ICDs and stuff, there's a little box on page 773, and it tells you about patient care and teaching with it. The big thing is just to, avoid direct, even with the pacemaker, avoid direct blows. Tell them to be very careful. Tell them not to get hit in the chest. Anybody at any age can have pacemakers. The little babies with heart problems have pacemakers. Older people have pacemakers. So that needs to be a question, especially if you ask them, have you had any recent surgeries? Have you had any recent heart problems? Ask them if they happen to have a pacemaker. You're also going to be able to see the scar on the left side of their chest. Now, sometimes if they have had a problem with their pacemaker and they go in to try to remove it, like change the battery because they're only good for 7 to 10 years, and they've had it for a while and they're changing it, sometimes if there's a lot of scar tissue in there or there's been an infection, they will move it over to the right side of the chest. They don't like to do that very much because it just is problems with your leads and stuff, but typically it's going to be on the left side. But if you see one and they say it's over on the right side, that can be normal in certain circumstances depending on what's going on with that patient. So, what are some of the indications for pacemakers? Initially, it is indicated for symptomatic bradyarrhythmias. Remember when we talked the first day about what bradyarrhythmias are? It's the heart rate is below 60. In and of itself, they aren't going to really worry about it, but when you start having somebody that is having a very slow heart rate for a very long period of time, no matter what kind of medication and stuff they're on, they're going to go ahead and they're going to put a pacemaker in to get their heart rate up to a certain point. Some people, do fairly well with their heart rates in the 50s, but that's not really good cardiac output. But they may go ahead and put one in, and if their heart and set it to where if their heart rate dips below hits 50, then the pacemaker will jump in and it will do what it needs to do and kind of kickstart the heart's beating a little bit faster. Anti-tachycardia and override pacing, I talked a little bit about that in the previous slide. This is when the pacing is going really, really fast. They want to slow it down. So, due to the delivery of stimulus to the ventricle, they want to terminate the tach dysrhythmias. So it's just like an electrical device that is meant to kind of help shock if it's an ICD, or it's meant to kind of make the heart kind of beat, and then it's kind of like gets it to, with the leads in there, it gets it to kind of maybe slow down and get to working back towards the regular rhythm. The tachyarrhythmias is usually where you will see your ICDs on that. Overdrive pacing. This is pacing the atrium at rates of 200 to 500 impulses per minute to terminate the atrial tachys. So just think of it as pacemakers are going to help more along the lines of your really, really slow heart rates with it to your tachys with it. Sometimes they will put it in there for people with AFib. Just depends on what is going on with that heart. Depends on if they have issues with trying to regulate the heart with it. So what they're going to do is it's either going to help with a very slow arrhythmia or an arrhythmia that it has to do with the pacing with it on that. As with anything, especially if it's mechanical, one of the most common problems with a pacemaker or even an ICD is a failure for it to sense. And that could be due to a lead, because when you get the pacemaker in there, you put the leads in first and then you attach the leads to the pacemaker. And there is a picture of a pacemaker on page 774, figure 3525, and that is, if you look at the very top of it, there is a clear plastic top where you screw in your lead to your from your right ventricle. So you're going to screw that in there. Now, if it's what they call a dual pacemaker, it's got one on the bottom, and some of them have it, depending on the manufacturer, some of them have two on the top where you screw in the leads. So some of them will have one lead, some of them will have two leads with it, just kind of depending on what they're wanting to do. So what happens a lot of times is the leads, they don't get connected very well, or they come undone with it. So then they fail to recognize what is going on, and they're not able to work. It may cause if they have an ICD to fire inappropriately with that. There might be some damage to the lead. It may be old, and they may have been in an accident. Something may have happened to one of the leads, like where it's pinched or whatever. So it may have something to do with that. Battery failure, dislodgement of the electrode. We talked about that. Also, a few years ago, there was about 2 years ago, right after the first year, I believe in 2015, there was a big recall of St. Jude pacemakers. There was an issue with battery life. They would put it in and the battery would drain very quickly, so then people were having to go back in and get pacemakers put in. Usually they're supposed to last 7 to 10 years. A lot of these batteries from St. Jude, pacemaker batteries from St. Jude, were lasting 2-3 years. So sometimes the patients were having to go in and have them taken out. Now once they have a pacemaker in, they will be checked. Some of them you can check at home, where there's that big blue magnet I'm sure you've seen, to where you put it over the heart, over where the pacemaker is, and it disrupts the pacemaker to where you can see if the heart rate is beating. If you're doing it at home, you have your phone connected to a machine and you do that. But the easiest way is for you to go to the patient to go to the cardiology office with a pacemaker tech, and they will check it. They usually check it either monthly or 2 monthly, depending on the provider and depending on how long they have had it and if they're having any issues with it. Okay, now we're going to talk about hypertension. As we know, hypertension means high blood pressure because of the hyper part of it. And that is just basically, if you remember your basics of anatomy and physiology, blood pressure is the force exerted by the blood against the walls of the blood vessel. And it must be adequate to maintain tissue perfusion during activity and rest. So, blood pressure is primarily a function of cardiac output and systemic vascular resistance. So this is why, when we talked a little bit about left and right-sided heart failure, you would see a lot of either hypotension or hypertension going along with the disease process with it. So there are two types of hypertension. We talked a little bit about this before we went to clinicals. There's essential and secondary hypertension. So we're going to look at we're going to learn to differentiate between risk factors, signs and symptoms, diagnosis, medical treatment, and nursing care with it. One of the things to keep in mind about hypertension is it is one of the most easily modifiable health issues out there. To catch it early with it, you have people that, if you think back to your CNA and stuff, your instructor talked a little bit about pre-hypertension. So that is why it's very important you start educating people about tobacco use, alcohol use, stress reduction and stuff when they're at that pre-hypertension on that, so that you can try to help modify it. You can try to do the easier things first before maybe they end up on any medication with that. Okay, so the one thing about hypertension is to remember is that the sympathetic nervous system, it will react in seconds after a drop in blood pressure. It increases blood pressure primarily by activating the sympathetic nervous system. So if you have an issue that increases the sympathetic nervous system, it means that you're going to have a problem, or the blood pressure is going to be elevated with it. So just kind of remember you know, if you have an elevation in blood pressure and stuff, it might be due to the, you know, something happening with the sympathetic nervous system with that. The neurotransmitter norepinephrine is released from the sympathetic nervous system nerve endings, and norepinephrine activates receptors located in the SA node, myocardium, and vascular smooth muscle. This is the response to the norepinephrine. The response to the norepinephrine depends on the type of receptors present. The central nervous system receptors are classified with like your alpha and your beta, and the smooth muscle of the blood vessels have alpha adrenergic and beta adrenergic receptors. With that, so that in and of itself is just kind of telling you that depending on the medication and which receptor it is, depends on how, you know, your heart rate is going to go up, what is going to go on with your system with it. It might be something that fight or flight, your heart, you know, something happens, it gets your norepinephrine and your adrenaline get released, your blood pressure goes high. Once the system, you know, you kind of calm back down, then your blood pressure is going to calm back down. Same thing happens with exercise. Your heart rate is elevated, and then once you relax, then your heart rate will go back down, your blood pressure will level out. But in some people with hypertension, there isn't that relaxation. There isn't the going back to the normalcy. It stays up there. So that is why, you know, stress plays a big factor in it. Tobacco use plays a big factor in it. That's why some of these things that are very easily modified play a big factor in hypertension with that. Okay. The bare bones simple definition of hypertension is it's a persistent elevation of your systolic blood pressure, and that means the blood pressure, for it to be considered, needs to be 140, or a diastolic blood pressure that is greater or equal to 90. And they are currently on antihypertensive medications. There are medications that sometimes you'll see people that are on 2-3 different hypertensive medications. They're doing something totally different. They may be trying to bring down the top number and the lower number. Sometimes if the top number is high and the lower number is really low, they might be trying to work each other. Sometimes blood pressure medicines will do a really good job lowering the systolic blood pressure, but it will take the diastolic down too low, so then you need to give them a medication to bring up that diastolic number. So sometimes you have medications doing different things with it. So this is where, you know, you just need to, you're looking at, hey, they're on, you know, they're on 2 different antihypertensive blood pressure medications. Why? Look up what the drug is and see what their mechanism of action is. And we'll really get into that when we talk about pharmacology next year with it. Okay, now we're looking at a little graph that kind of shows you factors influencing blood pressure. You can see where cardiac, your heart rate, your contractility, your conductivity, it goes down, it goes to your cardiac output. Blood pressure equals your cardiac output times systemic vascular resistance. So it's just looking at how your heart is contracting and relaxing and how the rest of your systemic vascular system is resisting. The sympathetic nervous system, we talked a little bit about that, your alpha adrenergics, your beta adrenergic vasodilation, which play a part into your systemic vascular resistance. And you're looking at you look at the systemic vascular resistance for local regulation of energy. With that, you're looking at vasodilators, your prostaglandins, your EDRF, and your vasoconstrictions and endothelium. With that, when you look back over at the cardiac output, you're looking at your renal fluid volume control, your renin-angiotensins, your aldosterone system. You're looking at, you know, the things that kind of the renal part of it. You know, if you stop and think about how your circulation works throughout your body, how it goes through the renal system and stuff like that. And then you're also looking at your neurohormonal, because hormones also play a big part in, you know, like how fluid comes in and out of the cellular levels with that. So this is just kind of an overlook at how hypertension develops when how it develops. Now remember that it's going to develop when one or more of the blood pressure regulating mechanisms are defective, like your EDRF or your endothelin, which is more of like a relaxing factor. So if you have a breakdown in one of these areas, like your prostaglandin or maybe your EDRF system, then you're going to have, that's when you start seeing your issues with your blood pressure on that. Okay, classifications of blood pressure. When we look at it, you can see that the normal blood pressure is 120 or less systolically, and diastolically it's 80 or less. So when you get into the prehypertensive, you're looking at 120 to 139 systolically, or diastolically 80 to 89. It's easier to try to have somebody modify their diet in this prehypertensive era section, when they hit this category. Because once you start hitting like stage 1 and stage 2, you're looking at, you're going to have to not only do modifications, but you're going to have to do medication. And usually if it's stage 2 and stuff, then you're starting to see damage to like the eyes, heart damage, more physiological damages with it. So with hypertension, there's primary hypertension or essential or idiopathic hypertension. This is when the blood pressure is elevated without an identified cause, and about 95% of the cases with hypertension are idiopathic or primary hypertension. Although the exact cause of the primary is not really known, there are some precipitating factors with it. There might be a problem with increased central nervous system activity, overproduction of sodium retaining hormones, greater than ideal body weight, diabetes, tobacco use, and excessive alcohol use with that. And the reason, and if you think about the reason with it, it constricts the vessels and it makes the heart work harder, so then your blood pressure is going higher. Excuse me. Secondary hypertension is an elevated blood pressure with a specific cause that can be identified and corrected. This type of hypertension accounts for 5% to 10% of hypertension in adults. This type of secondary hypertension should be suspected in people who suddenly develop high blood pressure, especially if it is severe. This is kind of where you see like in the stage 2 area. With it, the clinical findings suggest that secondary hypertension relates to the underlying cause. For example, abdominal bruit heard over the renal arteries may indicate renal disease. So they have something physiologically, something going on with a body part, like the kidney areas. Coronary disease. There is a secondary reason. There is a reason why they have the secondary hypertension. It's an effect of something else going on with it. Treatment of secondary hypertension is aimed at removing or treating the underlying cause. This is where, if you have something wrong with the renal arteries and stuff, they're going to go in, they're going to maybe scan them, they're going to do some work to see if there's a reason for it. So, they're going to try to go to the root cause of what the secondary hypertension is. So, with that, there's pathophysiology of the primary hypertension. So this is where the blood pressure rises with an increase of cardiac output. On that, the increased cardiac output is sometimes found in the person with prehypertension. So, like I said, it's very important to catch somebody at the prehypertensive level so you can try to modify their lifestyle and modify their diet with that, to help maybe get everything back into where it needs to be without any medication. So if you have somebody that they're very healthy physically, but all they do is maybe smoke, you need to try to encourage them to quit smoking with that. Okay, there is a subtype of hypertension. It is called ISH, or isolated systolic hypertension, with a systolic blood pressure that is greater than 140 and a diastolic that is less than 90 with that. And in that, you're looking at, the systolic blood pressure, it increases with aging. The diastolic blood pressure rises until approximately age 55. So you're just kind of looking at isolated parts of it. So control of the ISH decreases the incidence of stroke, heart failure, and death. Excuse me. So when you're looking at doing this, you're looking at the blood pressure classification, and it's based on confirmation of the Office of Blood Pressure readings with the ambulatory blood pressure monitoring. So if you look at table 32-2 in your book on page 684 and look at the classifications of hypertension, you see that the isolated systolic hypertension, or the ISH, falls into the category of stage 1, because you're looking at the systolic of 140 and the diastolic between 90 to 99. So it will fall into that. So it happens because as a person sometimes gets older, not every elderly person is going to have this issue, but depending on what is going on with them, they might have, a problem with and the isolation of the systolic blood pressure being elevated with that. Excuse me. Okay, now we're going to look at the etiology, or the reason why, the breakdown of hypertension. Primary hypertension, which is we talked a little bit about, is your essential or idiopathic hypertension. You have an elevated blood pressure without identifiable causes. Like I said, you're looking at about 95%. Typically, the book says 90 to 95%. I would probably say about 95% of all diagnoses of hypertension are going to be your primary or essential with it. The thing that I want you to look at, because I've already talked about some of this, is that the disease process of some of these things. People with diabetes, people that are overweight, even though a lot of times the ideal body weight or your BMI, it kind of depends on how the doctor is. If you have people that are over their ideal body weight, which when we're looking at it, we're looking at their height, and then if they're male, they're female, and it's that scale you look at, says, somebody 5'2", that's female, that's between the ages of 24 to 30, needs to weigh between like 110 to 115 pounds. That's what we're talking about on that. Increased sodium intake. This is when you're doing your assessment, you need to ask them, do you eat a lot of canned foods? Do you eat potato chips? What is your sodium intake with it? And excessive alcohol intake with it. Now, secondary hypertension, we're talking about elevated blood pressure with a specific cause. 5 to 10% of adult cases. I'd probably say it's more around maybe 8% of it. Contributing factors, you've got something going on with the aorta, you've got a renal disease going on, you've got an endocrine disease, neurological disorder, cirrhosis, or sleep apnea. Some of these are very easy to take care of. Liver cirrhosis is not as easy to take care of. But a lot of these, sleep apnea, BiPAP, CPAP. So they might once they have that, they sleep better. Everything relaxes in their system, and you can kind of control their blood pressure with it. So it just kind of matters it does really matter what is going on with the person. Now, the other thing that you need to remember is that hypertension is also called the silent killer, because frequently it goes asymptomatic. You can have people that have had high blood pressure for years and not know it. Some people, you think their blood pressure is high, they should have a headache, they should be feeling terrible, but a lot of people have learned to compensate and deal with it, and they just don't feel about it until they have a heart attack. They don't realize something's going on until maybe they get really sick and they go into the hospital or the clinic and they get checked out, and then they go, oh, you've got really high blood pressure, so we're going to start treating it. So, it doesn't always mean that somebody that is fit, that is overweight and smokes, they're going to be the only ones that have this. Sometimes it's your athletic people that have it. Some people, but they don't realize that they have the high blood pressure. So this is why they call it the silent killer. Okay, now risk factors. We talked a little bit about it in the etiology. Age. The older you get, the less flexible, elastic that your arteries and stuff get. So a lot of times your elderly people will be prone to having essential hypertension or a form of hypertension because their body is just working so much harder. Remember when we talked about cardiac output and stuff? This is something that happens as you get older. Not everybody that's older has problems with it. Some of them have problems with low blood pressure, but a majority of them do have it. Ethnicity with it. When we talk about that, African Americans have the highest incidence of prevalence of hypertension, and followed secondly by white people. Now, Mexican Americans are less likely to receive treatment for hypertension than whites and African Americans. They have lower rates of blood pressure control than the whites and African Americans with it. So it kind of depends on the culture that you're in, because some cultures they may not always believe in going to be in and be treated. Some cultures, some groups of people don't have the ability to go in because they can't afford to be treated also with it. So just keep some things in mind. The biggest thing to keep in mind is to remember that not everybody that comes in that has high blood pressure is in denial about it. They may not have even known they had high blood pressure with it. If you look on page 685 in your book, it shows you table 32-4. It shows you the risk factors for primary hypertension with it. Family history is another thing that is a big deal with it. And obesity. If you have, remember I talked about you need to get your serum lipids and stuff. If you've got clogged, when we talked about some of the heart diseases and stuff and the ischemia, if you have some of the blockages in your arteries, what happens? Your heart is working harder. So if your heart is working harder, your blood pressure is going up. So if you have a blockage or multiple blockage due to cholesterol, then you run a higher risk for having hypertension with that. Okay, pathophysiology of primary hypertension. We've already talked about some of that with the risk factors. Hereditary, if your father, your grandfather and stuff have a history of high blood pressure, then you have a 50-50 chance of having high blood pressure. In most cases, hypertension results from the interaction of environmental factors, demographic factors, and genetic factors. So sometimes it's where you live, it's your lifestyle, it's how you eat, it's environmental. If you live in a very stressful environment, that can contribute to it. Water and sodium retention. People that have problems with edema, they're not able to flush out the water. They retain the water, which means they retain the sodium, so they're not getting it out of their system. People with reduced kidney function run a higher risk of having problems with high blood pressure. High sodium intake may activate a number of pressor mechanisms which result in water retention. So if you eat a lot of salt, and people don't a lot of times think about canned foods as having a lot of salt in it, or processed foods having a lot of salt in it, but they do. They just stop and think. They use it to help preserve the food, so it lasts longer, for a longer shelf life. So that's when when you're educating your patient, you need to educate them that you need to look for how many grams of sodium are in your diet, and try to keep it below the FDA recommendations with it. Certain demographics are associated with salt sensitivity. Some people just can't take it. They retain fluids a lot easier. Obesity, increasing age, and we talked about African American and people with diabetes and renal disease. Those are things that we'll talk a little bit more about it when we get into those diseases and stuff, but really they play a very big part of it. So typically if you have somebody that has diabetes or renal disease, you're going to expect to see high blood pressure with that. Okay, what plays a part in primary hypertension? Stress and increased central nervous system activity. You've got a production with the increase of vasoconstriction, increased heart rate, increased renin release, insulin resistance, and hyperinsulinemia. High insulin concentration. If you look at the insulin, it stimulates the sympathetic nervous system to activate and impair the nitric oxide and mediate the vasoconstriction. Basically, if you have somebody that has high doses of insulin in their system, it causes the central nervous system to kind of go a little wacky and overproduce medication, which causes vasoconstriction. So a lot of times they have that vasoconstriction, and think about what vasoconstriction is. It closes the vessel, it constricts the vessels, so then it's causing the heart to work harder to produce the cardiac output with that. So this is just kind of just an overview of what I've already talked about with some of the things. Fatigue, reduced activity, you are going to see that. They're just going to be really tired. They may be dizzy because their blood pressure is too high. They may have a headache, palpitations. With it, dyspnea, their heart is working so hard to try to maybe get through some of the constrictions with it due to either blockage or vasoconstriction. So they may have dyspnea. They may have some problems with that. But the thing you also need to remember is sometimes the symptoms are often secondary to a target organ disease. So maybe they have renal problems. So their blood pressure may be secondary to something with that. But on the other hand of it, you need to be careful. If you have somebody with high blood pressure, you need to make sure you get their blood pressure within the parameters and stuff of try to get it down into the normal area, simply because, or at least into the pre-hypertensive, because the longer that the blood pressure is elevated, the more damage to some of your organs that you're going to have. So complications to high blood pressure. Target organ disease occur most frequently in the heart, cardiovascular disease, heart disease, ischemia, brain, cognitive impairment, peripheral vascular, kidney and eyes. Peripheral vascular, we're talking about cold feet, cold fingers, the peripheral vascular has problems with that. Hypertensive heart disease, we talked about. Coronary artery disease, left ventricular hypertrophy, heart failure, stroke. It goes into the head. You have cognitive impairment. Sometimes you have a blood clot. High blood pressure sometimes can cause a blood clot. So you can have a stroke with that. Peripheral vascular disease, nephrosclerosis, or retinal damage. This is why when you go into the eye doctor, they take your blood pressure to see where your blood pressure is, and they scan your retina to make sure there is no damage if you have high blood pressure. So, what are you going to do to diagnose hypertension? So the first thing is a very detailed history and physical examination. You're going to take a blood pressure in both arms, and then what happens is you're going to use the arm with the higher reading for subsequent measurements. The blood pressure, remember, is going to be higher in the morning, and it's going to be lowest at night, because just, the way the body functions with that. You're going to use proper oscillator method with properly calibrated instruments. Patient should be seated quietly for 5 minutes in a chair, feet on the floor, arms supported at heart level. An appropriate size of cuff is necessary to ensure proper reading. If it's too big, the blood pressure is going to be low. If it's too small, you're going to have a false blood pressure reading with that. And at least two measurements should be obtained. So you're going to take the blood pressure on the right side, then you're going to take a blood pressure on the left side, or vice versa. Then you're going to wait, and then they may have you wait maybe 10 minutes and have them come back in and do it again with it. Or the person may be told, okay, go at home, have your blood pressure taken twice a day, both sides of your arm, and do a log, and then come back within so many days and have it looked at. But the idea is to make sure you've got the biggest thing that I've seen over the years is people using the wrong cuff. With that, if you have a problem figuring out how to choose an appropriate blood pressure cuff, come find me, come find Lonnie, come find Lori Lynn, Tracy, or Elizabeth, and we will help you we will show you and walk you through how to find an appropriate cuff size for your patient so you do not get an inaccurate reading. Okay, so in addition to checking your blood pressure and having them do it, they're going to do some lab tests. They're going to do UA, creatinine clearance, serum electrolyte glucose, bun and serum creatinine, serum lipid profile, ECG, echocardiogram. They're looking at not only, okay, you've got high blood pressure, you're pre-hypertensive, what might be causing it? Your echocardiogram is going to show how effectively your heart is pumping. It's going to show, if maybe you have regurgitation, you have pooling of blood. Which may be that you have a mitral valve or tricuspid valve that's not working properly. You're going to get your serum lipids, see if you have high cholesterol. We're looking for modifiable things. We're looking for things that we can easily do. They're going to do, your serum electrolyte glucose. Is your glucose elevated? Is your salt elevated? What is your potassium level? They're going to look at certain things to see if it's stuff that, okay, they need to be on a diuretic to help pull off some potassium and stuff like that. So the doctor is looking at several different things, and these are things that they want to look at to see if they can easily modify the heart disease without maybe doing any medication. Okay, hypertension, the hypertensive collaboration. You're looking at, we already talked about modifying things. If they are overweight, lose them. Something as simple as losing 22 pounds may decrease the systolic by approximately 5 to 20 millimeters of mercury. Dietary sodium, reduce it. You need to be less than 20.4 grams of sodium per day. So read your labels. Don't sit down and eat a large family size of Cheetos for your meal because they're going to be, very high in sodium. Moderation of alcohol consumptions. Men no more than 2 drinks a day. Women no more than 1 drink a day. Even though there are some studies out there saying that a glass of wine every day is helpful for heart disease and blood pressure and stuff, just do it. We're not saying not to drink. We're saying to do it in moderation. The key is moderation. The key is reduce the weight, get on a healthy lifestyle, exercise. The big thing is also reduce your sodium intake. That will help. So that means no sodas because they're very high in salt and sugar. Processed foods are also very high in salt. So be careful about, you'll sit down with them, you'll refer them to a dietitian to look at, better ways to eat and how to eat healthy. Okay. We talked about this yesterday. We're not going to go into this anymore. Hypertension care. Lifestyle modifications. Everybody knows what the lifestyle modifications is. We talked about it with the coronary artery disease and stuff, so we're not going to delve into it. I'm not going to delve into it. It's just remember, it's the same things we talked about. Modify your lifestyle. Big thing. At least 30 minutes of exercise. Typically, they say most days, but it is best if they do it every day. So if they need to go on and they need to have to treat the hypertension with drug therapy, they're going to give medication that's going to reduce systemic vascular resistance, reduce the volume of circulating blood, and you're looking at your adrenergic inhibitors, your angiotensin inhibitors, your calcium channel blockers, your diuretics with that. So you're looking at some medications that are going to reduce your systemic vascular resistance and reduce the volume of circulating blood. Your diuretics are going to pull off the excess fluid out of your system. When you do that, you're pulling out the excess salt. So, you're doing things here to help your body work better and hopefully lower your medication, your hypertensive need for that. So, you have a patient that is in the hospital or it comes into the clinic that you need to do some drug therapy and patient teaching. Remember, you're going to need to sit down with them. There's printouts that you can give them about what type of medication they're on, what it is, the side effects. So go over them with the important side effects with it. Help them identify and minimize side effects. So if they're on a diuretic, make sure that you remind them that yes, even though it's pulling out the fluids, they still need to, in order to maintain an electrolyte balance in their system, they still need to drink water. They need to maybe cut back, instead of 4 cups of coffee a day, 2 cups of coffee a day. They need to, be careful about that. Dietary, you sit down with them and say, don't sit down. You can have 5 Cheetos or 5 chips if you really need that, or sit down and have a few sunflower seeds, not the whole 5-pound bag of it. Moderation, you're going to teach them. You're going to teach them, okay, if I'm really dizzy and I'm having shortness of breath and stuff, and I just recently took my blood pressure medication, I need to call the doctor and report, I did this, now I'm feeling, dizzy, I'm feeling some of these side effects you told me to watch about with that. Some medications like metoprolol will cause sexual dysfunction in men, so you'll need to sit down with them and tell them that. But you can also tell them that there are some medications that they can take in conjunction with the metoprolol to help with it. That is something that the doctor, will also talk to them about, because they need to take it. They don't need to do it. If it's really severe, they'll try a different medication with them. Dry mouth, tell them to carry sugar-free hard candies to suck on to help with it. You can chew some gum that will help with it. Drinking fluids. But they also have over-the-counter stuff like biotin. It's like a mouthwash that you can wash your mouth out with that helps with a dry mouth. and frequent urination. You're going to see that because you're pulling all the fluids off. To get it out, it goes to the kidneys, and you urinate a lot. So that's why you tell them to be careful about, don't take any diuretics past 1 o'clock in the afternoon, because then you're going to be up all night going to the bathroom on that. And tell them if they're going to go on a trip, maybe take it early in the morning or whatever, but try not to skip the diuretic. If they're going to go on on a cruise or something, have them visit with their doctor about, how they can do the diuretic with it. That way that they're not taking the diuretic, because some people are just on a diuretic alone to treat their hypertension. So you don't want them, to not take it and then have problems with edema and then have problems with their blood pressure on that. So, as you can see on this side, benefits of lowering your blood pressure: it reduces your incidence of stroke 35 to 40%, a heart attack 20 to 25%, and heart failure 50%. So it's very important to really, get them to understand that you're going to improve their health, they're going to reduce their risks of stroke or a heart attack or heart failure by, it's at least 50%, especially with heart failure, because you're taking all that stress off the heart, and the cardiac output is settling back down to where it needs to be. Now, keep in mind, you'll also need to remind them that there are going to be probably some predisposing factors, such as, kidney disease. If they have already advanced coronary artery disease, they may not be able to totally reduce their risk, but every point that you can reduce your blood pressure, you're reducing your risk for these 3 major diseases. Okay, we've already talked about this, about them going home, about discharge planning. This all goes into this. So I'm not going to go over it. So this is just a reminder of what you're going to do if you need to do patient teaching, discharge person from the hospital, if you're a home health nurse and you've got a newly diagnosed patient that has hypertension. So these are some of the things that you're going to do with it. Okay, I've already talked a little bit in previous slides about this for treatment of hypertension. So the biggest thing you're going to probably run into is the demographic and ethnic groups with it. Prevalence and severity of hypertension is increased in your African American population with that. Your Mexican Americans are less likely to receive treatment for hypertension than whites and African Americans. And your Mexican Americans and Native Americans have lower rates of blood pressure control than the whites and African Americans. That is basically because they do not seek traditional medical help sometimes. With your Native Americans, they will go to the medicine man. Your Mexican Americans have a tendency to go and do their cultural treatments and stuff like that. So it just kind of depends. Sometimes some people just don't want to deal with it also. So keep in mind, that's with any ethnic group. So just work with them. If you're meeting a lot of resistance with it, you may need to come back, especially if in the hospital, come back and revisit with them on that. So, it may be a multifaceted. It may be you plus a social worker plus, the family working with this person to get their blood pressure lowered with it. And sometimes they don't want to alter their diet. Sometimes some cultures have a higher tendency to have higher salt intake with it, because of the way they maybe prepare their foods and stuff. So that sometimes can play into that. So a lot of times it's about education and trying to work with them. And sometimes it's, I'm not going to change my diet. So then if you're not going to change your diet or lifestyle, then you're going to have to be sure you take your medication with that. Okay, hypertensive crisis. This is when you have a diastolic blood pressure that is severe and abrupt increase, means it goes over 140 millimeters of mercury. The rate of increase in blood pressure is more important than the absolute value, basically how fast it is going up. It often occurs with patients with a history of hypertension who have failed to comply with medications or have been under-medicated. So maybe they're in a poorer community and they're not able to take all the medications, so they're not going to be taking maybe your statins, or they may need to have 2 hypertensive medications but can only afford to take 1 hypertensive medication. So that's what they mean by under medication. And it can also be related, you'll see it typically in people that also have cocaine or crack use with that. So if you have somebody come into the ER and you're working the ER and you see that their diastolic blood pressure is above 140, they're entering into a hypertensive if it's like 138 and it keeps climbing, that means they're headed towards a hypertensive crisis with that. So, how are you going to treat a hypertensive crisis? You're going to hospitalize them because you're going to need to give them IV drug therapy, and they're going to titrate it to the mean arterial pressure. They're going to start them at a certain dose with some of their medications, and they're going to try to lower that level. They're going to try to lower that diastolic blood pressure. But in order to do that, they're going to have to start out at a level and increase it and titrate it until they can get it to where that blood pressure starts coming down. Because you don't want to do it too suddenly, because then you could possibly bottom out that blood pressure, and then you have another problem. They're going to have them on telemetry. They're going to have them on I&O. They're going to do neurological checks to see if they're showing any signs of a stroke. Facial drooping. What's their cognition? They're going to try to determine the cause. They're going to draw labs. They're going to do a narcotic check on them. They're going to see if they test positive for cocaine or crack, or even now at this point in time, bath salts. So they're going to do some of those things. They're going to also see what their lipid levels are doing. They're going to see what their electrolyte levels are doing to see if that may be the possible cause of it. And then once everything kind of settled down and stuff, then the education on this is how you're going to teach your patient. Be careful, take your medications, change your lifestyle, monitor your blood pressure. If you start seeing your diastolic blood pressure starting to increase, go to the ER or call your primary care physician, and get in as soon as you can to have it treated with that. Okay, most commonly used medications and treatments. The DASH diet. This is the diet I've kind of referred to off and on by one of the cardiologists I work with. If it tastes good, throw it out. If it tastes like cardboard, you're on the right way. You can find the DASH diet explained on page 688 in your textbook. It is very much a very strict sodium diet. A lot of times you will see somebody that is of like stage 1 or stage 2 on what they call a restricted sodium diet, a 2-gram sodium diet. So if you stop and think, it's like your FDA recommends 20.4 grams of sodium per day. So if you're thinking, oh, that's okay, I can do it, 2-gram sodium diet isn't that much, it really is a big difference. It is a very bland diet with that. Diuretics. You're going to use your thiazide and related diuretics like your HCTZ or Diurel. You might have people on 2 different diuretics. You may have them on the thiazide. You might have them on the loop diuretic like your Bumex, your Lasix, or your Demodex. You may have them on your potassium sparing, which is your triamterene. You're going to have them on your ACE inhibitors, adrenergic blockers, and direct vasodilators. So you're going to have them on these medications. You may have them, like I said, on two diuretics, but you're probably going to maybe have them on like clonidine or Minipress, or you may have them on like hydralazine, and they may have nitroglycerin, PRN, a sublingually to take, or they may be on a nitroglycerin patch, depending on what's going on with that. So you may have them on one or a combination of these medications. Just depends on how high their blood pressure is and what their lab work is also showing. You'll also have them on like statins to help lower the cholesterol. Okay, we've already gone all over this. I'm not going to repeat this again, but it is still important. Just remember, when you're in doing patient education, client teaching, this is what you're going to educate. Decrease salt intake. Use salt substitutes. Use different things. Use nutmeg and Mrs. Dash and some of these other things out there. These different seasonings that are low in salt to add flavor to their food with it. So have them visit with a dietitian if they're struggling with it. Monitor your blood pressure. Sometimes they will have them do it 3 times a day, 2 times a day, 3 times a day if they're newly diagnosed or they're more along the stage 2 with it. Reduce their stress. Exercise. So just things what we've already talked about. Just kind of a reminder, this is kind of what your educational process is going to be. Okay, we're almost done with this PowerPoint presentation. So we're going to talk about vascular disorders. Now we've already talked a little bit about vascular disorders, so this is just I'm just going to go quickly through this. This is basically, we're talking about like stasis ulcers, varicose veins, and stuff like that. Okay, when we talked about heart disease and stuff and heart failure, we talked about PAD, peripheral artery disease. This is where there is thickening of the arterial walls. It's related to other types of cardiovascular disease. Atherosclerosis is the main cause, is the leading cause. Blockage of the arteries. If you remember back what we talked about with atherosclerosis, What it is, it's the thickening of the walls due to the buildup of plaque. With that, so you see coronary artery disease and peripheral artery disease. They're a big issue with this. When we're talking about peripheral, we're talking about anything below the waist. So this is what we're talking. Coronary artery disease is anything above the waist. Peripheral vascular disease, or peripheral artery disease, is anything below the waist. So now that when we talk about peripheral, remember, it's going to be typically more about problems that are going on with your lower extremities. Okay. Even though in the previous slide I just said peripheral artery disease is seen mainly in the lower extremities, it can also be seen in your hands and your arms. If you think about peripheral, it's kind of like the outer part of your body, where coronary artery disease, is like from the waist up in your chest area and stuff like that. Sometimes you may see diseases like in your hands and stuff, and we'll go over that with a couple of them, that you'll see in your fingers and your toes, and it's due to some with the peripheral arteries with that. So your risk factors we're looking at, once again, is tobacco use, chronic kidney disease, diabetes, hypertension, hypercholesterolemia. Women and African Americans are at higher risk for it. Gender plays a big part in it. Okay, clinical manifestations. The severity of it is going to depend upon the site and the extent of the blockage. So one of the most common things is intermittent claudication. We talked about this a little bit. At the very first day, it was just a very brief little blurb I said, and this is where there's ischemic muscle pain caused by exercise, and it will resolve within 10 minutes or less with rest. This is what happens is during exercise you have some vasoconstriction going on, which decreases the blood flow, or if there's like a blockage there, it stops the blood flow to the muscle, and like in your legs and your calf, and you really get a lot of pain in that area. So then once you stop, everything dilates out and the blood flow gets back, it gets back to there. So if you have a blockage and you have a constriction, it's stopping the blood flow. So if it's not, the artery is not completely blocked off, and you've got a little bit of area for the blood to flow, then once you relax and you get the blood flow going there, then you're getting blood back to that area with it. So one of the ways that they test for it to figure out is they may have them exercise for a couple of minutes on the treadmill, or until they get some pain in the area. Then they'll have them go to the lab and have a lactic acid level taken, and that's because there's a buildup of lactic acid, so their lactic acid levels will be extremely elevated, and that's one of the ways that they can diagnose this ailment. And as many as 1/3 of patients with it with peripheral artery disease report that they have intermittent claudication. Another part of it is paresthesia, numbness or tingling in the feet or toes. You see this a lot in diabetics, people with peripheral vascular disease. It's like the neuropathy, it's the damage to the nerves, and they get this like tingly, like their foot is always asleep or they're walking on pins. It's because there is constricted blood flow due to a blockage, nerve damage. So this is where that is coming from on that. Okay, complications are that the lower extremity peripheral artery disease progresses very slowly. Prolonged ischemia will lead to atrophy of the skin and underlying muscles, where you have the death of the tissue or the area. Ulcers are difficult to heal due to poor circulations, and if severe enough, amputation of extremity may be required. So the impaired circulation causes problems. So along with that, then this is where a lot of times you see toes are amputated because there is lack of circulation due to blockage or whatever. So they may have to go in and amputate it because it's never going to heal. Okay, your diagnostic studies are going to be your Doppler ultrasound with duplex imaging. That means it's like a 3D imaging. You're looking at the blood flow. You're looking to see what's going on with it. Health history, and then ankle brachial index. If you look on page 805 in the textbook at table 37.3, it shows you exactly what it's talking about as far as with interpreting the ankle brachial index results. So excuse me. So with that, you look at it, it just kind of this is something more a doctor is going to do, but this is kind of a diagnostic test with it. So just kind of look at it and just kind of see. It just looks at the severity of it, and it tells you kind of what the doctor is looking for with it on that. Okay, management. Cardiovascular disease risk modifiers. We've already gone over this. This is just a reminder. This is what you're going to try to do. We've already talked about a lot of it. I'm not going to go over in depth on it. Exercise, lose weight, reduce blood pressure. You're going to treat the hyperlipidemia. Antiplatelets, so something like a Plavix is what they're going to do. Surgical intervention, by that they mean they'll go in and they may do a bypass graft to the lower extremities, stimulate the blocked artery or veins with it. So we've already talked about some of this when we talked about coronary artery disease. The same thing is you can do peripherally with that. Acute arterial ischemic disorders. Acute arterial ischemia is an interruption in blood supply to tissues. It's caused by embolus, thrombus, or pre-existing thrombus from a heart AFib. So remember we talked a little bit about this when we talked about AFib. And the clinical manifestations, you're looking at the 6 Ps. You do need to be familiar with this. You do need to kind of, if nothing else, make a little cheat sheet, put it on the back of your ID badge. You need to look at it, so you need to know. You need to look at the 6 Ps. You're looking for pain. Where's the pain? What's the intensity of pain? Is it pallor? Is the skin really white? Pulselessness, is there a pulse? Paresthesia, is there a tingling feeling of it? Paralysis, can they move? And poikilocardia, what is the temperature of the skin with that? So these are things that you can look at as you're doing an assessment with somebody that is, complaining of pain. If you suspect somebody of a thrombus in their lower extremity, you're looking at it to see what is going on with it. Okay, these are some of the diseases I was talking about that are on the peripheral side, where you will see not only in your lower extremities but also in your hands. Buerger's disease. This is a non-atherosclerotic segmental recurrent inflammatory disorder of the small and medium arteries of the veins. It occurs mostly in young men with a long history of tobacco use. Thrombus forms and causes blockage of the vessel. The treatment is going to be very conservative. You're going to avoid limb exposure to the cold temperatures, supervised walking programs. By that, you want to make sure that, they may not have much sensation in the feet. Be careful. Make sure their shoes fit correctly. Make sure that, they kind of look down or they walk with somebody so that they don't trip. There are going to be antibiotics and analgesics to manage the pain, because it does cause some pain with that. It is also known as thromboanginitis obliterans. Buerger's disease is the most common name with it. It also will occur. It also occurs in mostly younger men. When I say that, it's 45 years of age or younger is when it's usually first diagnosed with that. And they're usually, like I said, at risk for some of the cardiovascular factors, which are hypertension, hyperlipidemia, with that. So just kind of, with them, it's just, you're going to monitor them, make sure that they don't expose. You're going to really educate the, wear gloves when it's wintertime outside. Wear long sleeves, wear a coat, wear a jacket. You don't want to expose your extremities to that. Okay, another one is Raynaud's phenomenon. It's a vasospastic disorder of small cutaneous arteries, mostly common involving the fingers and the toes, and it occurs in women 15 to 40. The treatment is going to be patient education. During recurrent episodes, you're going to wear gloves to keep fingers warm, socks to keep toes warm, and then there's going to be drug therapy to kind of help open up the circulation with it. A lot of times, the women's fingers, your fingers will look extremely white. Your hands will be the normal skin color, and then around the neck, probably about your middle knuckle towards your fingers, it'll be really cold, and their fingers will be really, really white with that. So that's usually the first sign of it, is they complain about always having cold fingers, cold hands, and that's what you first notice with this disease process. Okay, aortic aneurysms. Aneurysms are a weakness in the wall of the artery. It occurs more in whites than in women. Incidence increases with ages, so the older you get, the more your risk for an aortic aneurysm occurs, and it's just basically there's a weakness in the wall. 3/4 of aortic aneurysms occur in the abdominal aorta, and 1/4 in the thoracic aorta. Growth rates are higher in patients who smoke. Stop and think. It's a weakness in the aorta. you're vasoconstricting constantly when you smoke and stuff. So you're causing it to work, that weak spot to work a lot. So that's where you get it up. And then if you look on page 811 in your book, it shows you on figure 37-5, it shows you the formation or the fusiform of the abdominal aortic aneurysm, and it kind of shows you how it kind of goes out, it bulges with that. And you can see these on chest x-rays or on a KUB. You'll see these on an x-ray or a CAT scan. They will show up on those. Okay, risk factors are going to be your age, your gender, hypertension, coronary artery disease, family history, tobacco use, high cholesterol, lower extremity, PAD, and obesity. So you can see a lot of things that contribute to cardiovascular disease also contribute to diseases in the other parts of your body with that. Okay, with your thoracic, you're often asymptomatic. You do not know what is going on until maybe you go in and you have like a chest x-ray done, or maybe you become, short of breath. They may develop a diffuse chest pain. It's just like a deep pain in their chest that kind of is like spread out. If it is occurring in the ascending aorta or aortic arch, they may have problems with angina, transient ischemia. They may develop cough, shortness of breath, hoarseness, or dysphagia. So the biggest complication is going to be rupture, depending on where it is at. If it's if it's in the aorta, that is closer to the heart. If it's a little bit farther down, where it's at in the aortic arch, depends on what happens. If it's an abdominal one, the life expectancy is, not very good if you have somebody with what we call AAA. The rupture is the biggest killer of them, because usually once it ruptures, if you think about the aorta, it's the biggest artery in the body that carries the blood. So if that ruptures, the heart is pumping, and you're gonna bleed out very quickly. So if you're in a hospital and you have a ruptured AAA, mortality rate is going to be 53%. They try to catch them early and go in and try to reinforce the area if they can do so. So surgical intervention usually will try to help with it. They try to go in and they try to repair it, maybe put what we call like a girdle, something around it to kind of help keep it from, continuing to grow and continuing to bulge and continue to weaken, which is where, a lot of times the rupture occurs from. Venous thrombus. Venous thrombus is the formation of a blood clot in association with inflammation of the vein. Deep vein thrombosis, superficial thrombosis. Patients with superficial thrombosis are 25% are more likely to have a deep vein thrombosis or pulmonary embolism. We've talked a little bit about this when we talked about your PEs and stuff like that. So just remember, this is why a lot of times if they have like AFib, when we discussed atrial fibrillation, you want them to be on blood thinners and stuff like that, so you do not develop a venous thrombus, because it can travel anywhere in your body. It can travel up into your brain. It can cause a stroke, and can travel into your heart, and it can cause a heart attack. So the idea is to find it, diagnose it, and try to treat it with blood thinners, so you're not having problems, and also addressing the inflammation of the vein. This is kind of like a Virchow's triad. It shows you where it starts over on the I'm facing the computer, so it'd be the left hand side, the endothelial damage, endothelial dysfunction caused by smoking, hypertension. The endothelial damage is caused like through surgery, catheter, like your PICC line, something that's damaging your artery or your vein, and trauma. Hypercoagulability, high ability to coagulate. You're looking at hereditary, which is like your factor 5, your prothrombin, your protein C(S) deficiency, which are issues with genetics, and then acquired cancer, chemotherapy, OCR, hormone replacement therapy, pregnancy, obesity, and your heart diseases and stuff like that. Then you're looking at your stasis, immobility, polycythemia, and these can cause, all these things here can cause damage to your endothelial. So any type of damage, starting IVs, you know, if you've got cancer, stop and think about what you do with cancer. You start an IV, you put like a port in, and you're putting chemicals in which are caustics, and it's causing damages to the vessels. Pregnancy, you know, you when you're looking at pregnancy, you're looking at the baby laying, maybe putting pressure on some of your arteries and stuff, which can cause some damage to it. With that, you know, anything, you know, causing lack of circulation, where the blood is going to pool and kind of coagulate together and stick together, that's going to form a thrombus. So this is why, you know, you need to, you know, get a very good health history on a lot of your patients. Okay, this is the risk factors for venous thrombosis. Stasis is you're looking at age greater than 40. Immobility, that means they're not moving, they're sitting in their chair. This is why, you know, with residents we tell you to get them up, do range of motion with them. If they have a diagnosis of CHF, they have a previous history of stroke, spinal cord injury, hyperviscosity, polycythemia, severe COPD, anesthesia. If you think about it, what anesthesia does, it slows your heart rate, it slows everything down. So if there's an area in the body where there's maybe a little bit of plaque that's, you know, or a pinch, like maybe in the coronary artery diseases that we talked about, like your left ascending, you know, artery, and you see that little pinch, if you think about that video we watched yesterday, so you've got everything slowing down, and there's just enough of a pinch, your blood is going to start, you know, pooling there, and it's going to start collecting, and then you can have the formation of a thrombus with that. Varicose veins are also with that. So these are just some of the things that we've already talked about a little bit. This just kind of gives you more of a detailed overview of what risk factors for are on it. So how do you treat and manage it? You're going to do labs. You're going to look at your ACT, which is your bleeding time, your PTT, your hemoglobin, your hematocrit, your D-dimer. If your D-dimer is elevated, it means you're at a higher risk for blood clots. You're going to do a venous ultrasound. You're going to do magnetic resonance venography. You're going to do a CTV. Medications, you're going to give them vitamin K. Indirect unfractured heparin. You're going to do things that are going to thin the blood out, decrease the ability of platelets to coagulate and to stick together with it. So you're going to do some of that. And if it's bad enough, they'll go in and they'll surgically remove the thrombus with that. If it's in your coronary arteries, then they're going to go in and they're going to suction, like that video he showed. They're going to put a catheter into the artery or whatever vessel's got it. And they're going to suck it out. They're going to try to remove that thrombus so it doesn't, you know, travel and get into like the brain and cause a stroke. Nursing management. Once again, as you can see, the big thing is health history. You need to do a really good health history with your patient and find out, you know, are they immobile, what kind of activities they do, have they had a history of stroke with that, what medications they are on. You know, remember what I told you when you're asking about medications. What over-counted the medications there are, what prescribed medications, are they seeing a specialist? Are they taking any herbal supplements? Do they go to a homeopath? And have they been prescribed any medications through that way? Surgical history. When was their last surgery? What types of surgery? You need to try to figure out all their surgeries that they've had. IV drug use, contraceptive use, hormonal replacement therapy. Measured affected extremity. You know, you want to see that, because a lot of times if they have a thrombus, it's going to grow in that area. So you're going to measure it. You're going to mark it, and then you're going to measure it. And usually it is measured like every shift or every 4 to 6 hours, depending on what is going on and how severe it is. Pain medication it causes severe pain, so you're going to give them an analgesic. You're going to give them maybe like some morphine to help with it. You may also give them an antipyretic, like maybe some extra strength Tylenol to kind of help with some of it, or maybe Advil. Skin assessment. You're going to monitor for open areas. You're going to monitor pedal pulses. You're going to if it's in the arm, you're going to monitor the brachial pulse with it. So you're going to monitor the pulses. Pedal pulse, you see this a lot in the lower extremity, so you're going to monitor pedal pulses with it. But if you have a problem in the arm, you're going to monitor the brachial pulse. And lastly, with nursing management, you're not going to, if you have problems getting IVs, if IVs are not your thing, you may call in the IV team or your CRNA to have them start the IV, so you're not puncturing them numerous times. Avoid IM injections. Avoid sub-Q injections if you can. But a lot of times they may give them Lovenox injections or heparin shots with that. Avoid restrictive tight clothing. Educate the patient and family to check feet for sores daily, shoes that fit correctly. You're going to have them obtain labs as ordered, especially once they go home. Encourage them to take their medications as ordered. Compression hose for varicose veins. Elevate legs. If they're in the hospital, they're going to have sequential, those sequential boots, and that a lot of times is going to be more for, like you'll see with really bad varicose veins. You're also going to do it preventatively if you have somebody that's had like a long surgery, like a knee replacement or a hip replacement, and they laid still very long. Even for an appendectomy, they'll have the sequential boots on because, once again, once you do anesthesia, then you're slowing the circulation, you're slowing the blood flow down. So you want to be sure that you get all that blood flow, you're assisting that blood flow back up to the heart with that.